you, Matt.
Great, thanks, Christine, and lovely to see you all, and really appreciated being invited today to talk a little bit about health inequalities. So as Christine said, my name's Matt Pearce, and I'm the Director of Public Health for Herefordshire. So I've been in post now for just over 2 months, so relatively new. So if I get any of the data wrong, statistics wrong, or comments wrong, hopefully that will give me a bit of a kind of a caveat out of that. But really excited to be part of this, mainly because I'm really passionate not only around health inequalities, but also the role of the voluntary and community sector. That's something I've been interested in for a long time, recognising and valuing their contribution to this agenda, because I think they have a really important role to play. So really the two key questions I'm going to cover, I've only got 20 minutes, I've got a lot of slides, I'm going to go over these quite quickly, and hopefully Christine will be able to share them afterwards. I think there's a lot of data in there that I won't be able to cover. I could do a whole day or week talking about health inequality. So I've tried to take out the key things that I think are important to maybe think about today. But the two things I want to talk about is what are health inequalities, and some of you will be very familiar with all this, and I completely understand that. How do we address them, and what do they look like for Herefordshire as well? So just over 10 years ago, I'm sure many of you be aware of a chap called Michael Marmot. It did a landmark report called Fair Society, Healthy Lives. And this quote is always quite poignant for me, where he talks about health inequalities are not inevitable. They can be significantly reduced, but avoidable health inequalities are unfair, and putting them right is a matter of social justice. So what really are health inequalities? We often talk about it, but really they are, as I said, unfair and unavoidable differences in population between different groups within society. And they are due to the conditions with which we live, which are we born, we grow, live, work and age. And there's different dimensions of health inequality. So on the right hand side, this comes from actually the NHS definition. They talk about socioeconomic deprivation, so unemployment, low income, deprived areas, equality and diversity, so differences in age and sex and race, inclusion of health, so particularly vulnerable groups that might be exposed to the different ways of living throughout life, and then the geography and the urban and rural split, which is particularly relevant to Herefordshire. So why must we act on health inequality? So why is this so important? Well, there's three main reasons really. The economic burden, so actually health inequalities cost society significant amounts of money. And they contribute to lost production and productivity. And then we also know there's a higher burden of disease in most deprived neighbourhoods, and costs the NHS 20% more per women and 16% more per men than the least deprived areas. But the most important for me is that moral reason. So 5.4 years and 4.4 year gap in life expectancy between males and females, between the most and least deprived in Herefordshire. And we'll go on to talk about that in a little bit. And again, we also know when we talk about deprivation inequalities, not just life expectancy, but the number of years that people live in good health. Healthy life expectancies tend to what we refer to is also a good measure. And we know that people in deprived areas spend nearly a third of their lives in poorer health compared to more affluent areas. What's been really good nationally over the last few years is the legal and institution requirements to tackle health inequalities. So CCGs moving to integrated care boards soon, they have a legal duty to have due regard to health inequalities. And the NHS long-term plan talks about health inequalities, and local authorities and health and wellbeing board, particularly in Herefordshire, as Christine said, is a key priority for us. I'm not going to go into this in too much detail, but again, this just causes about the complexity of inequalities. I think we have to recognise this is difficult stuff. It's not easy to come up with the solutions. It's very complex. There's interrelated, interconnected factors that lead to health inequalities, which is why it's so difficult for people to actually come up with the solutions. But there are opportunities and things we can do, which we'll come on to later. But for me, the wider determinants, the bottom left-hand side of this slide is really important. And some of you might be familiar, there's lots of statistics flying around that actually the NHS only contributes to around 20% of premature mortality in terms of early death. The large causes of early death come from the way we live our life in terms of employment, education, housing, natural built environment, and access to services. That's not to say the NHS isn't important, but actually a lot of the work that you do sat in this room is really important in terms of shaping people's lives and giving those opportunities. So, inequalities of what is about differences in status of people's health, but the term is commonly used to refer to differences in the care that people receive. So it can involve health status, for example. We've talked about life expectancy, prevalence of health conditions. We know people in more deprived communities have more multi-morbidities in terms of more long-term conditions. Access to care, again, very relevant to Herefordshire and our rural communities. The quality and experience of care as well is really important, and behavioural risks. So we know people in more deprived communities, they're also more likely to have ill health behaviours, smoking, inactivity, and poor diet, for example. And then I've also mentioned the inequalities between who, and I think this is really important. I've talked about the urban-rural split. I've talked about the specific characters protected in law, such as sex, ethnicity, and disability. And then socially excluded groups, you also need to think about those differences. Going quite quick, hope that's okay, there's a lot to get through. So what does this all mean for Herefordshire? And I'm conscious that public health constantly has lots of data and stats. I don't do too much data and stats to you today. Oh, go back. But obviously we know about Herefordshire, it's got an ageing population. We know that overweight and obesity for our younger population is an issue that we need to think about. Fuel poverty is 17% of our households are in fuel poverty, 14,000, and that's probably increased significantly since this data has come into play, given the cost of living crisis. Might be something we want to think about today. But overall, Herefordshire does have low levels of deprivation, but when you actually go down into the more intricate detail, there's often always a relationship between ill health behaviours and deprivation. So we have to need to unpick that data a little bit more detail. I've mentioned life expectancy already. I'm just going to pick out the right-hand side of this slide. So I'm not going to talk about this in too much detail, but this just looks at the life expectancy between males and females. So as you can see nationally, life expectancy is actually stored amongst males and females, and we have seen a slight decline nationally as a result of COVID-19 pandemic. Below that, you can see the healthy life expectancy in males and females, and the blue line reflects Herefordshire. So if you can just see, I've probably have got a point on here, but I won't know how to work it.
The red bit at the top.
The red one, is it? Oh, there you go. Just right, see that? So the healthy life expectancy you can see for males in Herefordshire has actually declined over the last few years to come more in line with the national average, which is down here. Although when you look at the females, the healthy life expectancy stayed relatively static. So it's just something to think about. So again, we often focus on the life expectancy, but for me, the healthy life expectancy in those years in good health is really important. So this just really shows the kind of gaps in life expectancy between different wards. This isn't necessarily a difference between affluence and deprivation, but it does show for males, so in Saxon Gate, 73.1 years is the average life expectancy for males, compared to Ledbury West, where it's 84.5 years, so a gap of 11.4 years. And then for females, there's a gap again, Saxon Gate and Leominster West of 11.5 years. So again, just shows that variation in life expectancy between some of our different wards. And again, I'll signpost you to information later on in the presentation where you can actually go and dive into this a little bit more detail. There's a lot on this slide, which I'm not going to go into, but this comes from our summary JSNA that we do every 3 years. It just goes into the detail of what are the key health inequalities for our population. So it talks about things like employment, the number of people out of work, benefit claimants. It talks about children and young people. So we know that education attainment is really important. How can we support those younger people gaining that good education, set them up for life? There's health inequalities. I'll talk about life expectancy. I'll talk about COVID-19 in a second. And there's inequalities in older people as well. So again, there's various different types of deprivation, inequalities that we need to be aware of across the county. So I said there are some key areas we know where some of that deprivation exists, and we tend to use something called the indices of multiple deprivation. So it uses various different domains and factors that comes together to give an overall score of how relative an area is to deprivation. And I'll talk about those in a little bit more detail in a second. But in general, people living in the 20% most deprived areas of Herefordshire are more likely to smoke, be overweight, be obese, die prematurely of cancer, respiratory conditions, and circulatory diseases. And these are just some of the areas we've picked out in terms of where, and again, I'm sure many of you in the room are familiar with some of the conditions and circumstances within what these people live within. And one of the things I probably should have mentioned at the beginning is actually data just tells one part of the story. And I think that's really important. We really need to combine that with the qualitative, the narrative, that local experience at that community level to really get a feel and understanding of those local areas. So obviously south of the city, we know that there's some significant challenges for our communities. Leinster, Ridgemore, Grange and Gateway, equally there's some opportunities that we might need to consider and look at and think about how we might support those people in those communities. And also in, is it Weebly? Is that how we say it?
Webley.
Webley, right, okay. I was worried about this. I was like, how do I say this? I'm from Gloucestershire, not Herefordshire. So again, there's some opportunities, but whilst it's a very rural community, we know there's some issues around housing and access to services as well, which is kind of why that comes up as an area of opportunity we need to think at. So I've mentioned a bit about rurality, and again, I think we just need to be conscious that when we look at the indices of multiple deprivation, it doesn't always play well when we look at rurality versus kind of the urban geographical spread. But on the right hand side, it just tells you the types of deprivation affecting rural Herefordshire are very different to urban. So if you look at the orange bar represents the urban, and around the outside, you've got the domains of the indices of multiple deprivation. So it's got indoor living environment, access to services, income, and so forth. And you see the two green areas that stand out is the indoor living environment and access to services. So very different in those rural communities. And it's not really a surprise, is it? Access to services in our rural communities are issues and something we need to think at. Indoor living environment can refer to the cost of living, the cost of rent and quality of housing too. So I had my team just do a quick bit of analysis on health inequalities as a result of the pandemic, because obviously nationally we've heard about individuals across the country disproportionately being affected as a result of COVID-19, and I want to understand how does that actually play out in Herefordshire. So on the face of it, Herefordshire's mortality rate in terms of when people die has been amongst the lowest in England from April to March, which is really, really positive. And throughout the trend in the course of the pandemic, the county's mortality rate for the whole of the pandemic is lower than the national average. However, as been seen in England as a whole, inequalities means that the impact was greater on the poor. So in a way, we've really seen that disproportionate impact, but it has actually shone a light and exposed health inequalities, which in a way has led to the government publishing a disparities white paper, which should be coming out hopefully in the next few weeks or so. So what we found is that over the course of the pandemic, people living in our most deprived areas in Herefordshire were 1.5 times more likely to die with COVID-19 than those living in the least deprived communities, which is quite a startling fact when you look at it. And when you look at the number of deaths, there's a table on the bottom left-hand side among community dwellings or houses within Herefordshire, where COVID was mentioned on the death certificate. Again, you can see the IMD on the left-hand side here, which is 1 being most deprived and 5 being the most affluent. And you can just see the mortality rate is a lot higher for the most deprived compared to the least deprived. So again, what's being played out nationally is also happening in Herefordshire. And again, when we look at vaccine uptake, we've looked at this. The first dose uptake in those aged between 12 and 54 is higher in Herefordshire compared to England and the West Midlands, so really good from that position. But actually, the vaccination uptake varies by ethnicity, being lowest in residents who identify themselves coming from a white background other than white British. And when we look at GP records, we see that actually Herefordshire residents from a white background, other than white British, Polish, Romanian, Lithuanian and Bulgarian. So see those migrant communities that we know exist within Herefordshire are disproportionately being affected in terms of uptake of vaccination rates. And again, the uptake of vaccination rates apply to deprivation. You could probably apply deprivation to any health outcome and there'll be some kind of correlation and relationship that exists. So in terms of the vaccination uptake, the LSOA areas, Hereford, Leinster, Bromyard and Ross-on-Wye are those areas where we need to do a bit more work to focus. And I know there's lots of great work going on by NHS colleagues here. How long have I got left, Christine?
5 minutes.
5 minutes, great. So the real challenging question then is how do we address some of these inequalities? And I think one of the first things we need to think about is the difference between equality and equity. So equality is giving people that same level of access to healthcare services and other types of services. But actually with equity, we need to give that different type of support. And that's really important, which is what the right-hand picture is all about. So just giving people that same access, same opportunity. We need to do more than that to really kind of change the curve on inequalities. And without getting too technical, because I've always struggled slightly with this term, this came out of the Marmot report. It's called proportionate universalism. Always a tongue twister. I always get it the wrong way around. But in essence, what this talks about, they talk about to reduce the steepness of the social gradient in health. Actions must be universal, but with a scale and intensity that's proportionate to the level of disadvantage. So what does that mean? So in a way, what that means is we have to have our services that are universally applied and supporting everyone where needed. But where there's greater need, that's where we need to put more resources in. And that's really where the equity comes in, equitable services. But many scholars have struggled to understand this concept in practice. I always think the health visiting service is quite a good example of this, because it talks about obviously everyone getting the number of 5 mandatory checks when you have a newborn child, but actually for those people that need that additional support, there's often more intense support given to those individuals and sometimes additional visits. For those of you that attended the vulnerability conference last week, symposium, we talked quite a lot about this. What do we mean by prevention, the 3 different tiers? Again, we just need to think about these in terms of people's stages of life, in terms of stopping the problem in the first place, the primary prevention, by far the most cost-effective way of doing it. Secondary prevention, so when people have identified as a health condition or diagnosis, how can we prevent that from escalating further? And then tertiary prevention in terms of minimising the impact and preventing that from happening. And I always put this one up. I think this is quite helpful to actually think health inequalities are really entrenched cultural challenges that we're not going to change today, and maybe not for the next 6 months, year, 2 years, and 3 years. And really what this diagram just shows is that actually different interventions have a different lifespan in terms of the return on that investment, both in terms of funding, but also outcomes. So when we're thinking about some of the actions we might want to collectively do, we need to be realistic in terms of, how long is it going to take for these changes to happen? What are the small things that can collectively happen that can make a difference? And I always like the sandbag analogy in terms of when you're holding back a flood. If you take one sandbag away, that's not going to help. You need all those sandbags in place to really make a difference. So just some key things for me, I'm nearly there, in terms of things that can make a difference. I think we have to look at the data. We can get a bit bombarded with that data. I said that the stories, the voices from our communities, our residents are really important, but data can help us identify where we might want to target and focus our efforts. And you and your service provision, you'll have some really rich data. How can we tap into that as well and understand the challenges you're facing? I think the insights of the lived experience is often neglected, and I think we need to add that into that discussion, listen to the people that are really experiencing these issues, the vulnerable, how can we support those? Empowerment approaches, when you look at the Marmot report, it is all about empowerment, social capital, community building. That's a great work around Tilt community, and there's lots of social capital in this room, and I imagine many of you are contributing towards that. And I've talked about equitable uptake of services. So do we really understand who is uptaking our services, particularly in statutory sectors, but also in the voluntary sector? And are there any barriers we are putting up in place that's inhibiting people's ability to go to those services? I think we have to recognise that many of the levers for health inequalities are at that government and national level. Many of those things are out of our control, but that's not to say we can't do some local things here. There are many things we can do. I think we do have to focus on the wider determinants. Healthcare gets all the attention, rightly so, but we just need to focus a little bit more in terms of those living conditions that really shape people's lives. And for me personally, that I'm very passionate about is giving the best child a good start in life. That's really where a lot of investment should really go into. That's where I know what the evidence says makes a big difference. So my last slide is really where to find out more information. That was very much a whirlwind tour. I think understanding Herefordshire, if you're not aware of it, it's a really rich source of data, information. It goes into all the detail that I've just gone into in a lot more depth. And it's a really good place to unpick it, look at ward profiles, inequality data, behaviour data. Marmot updated his review. It got published a couple of years ago. It's worth a read. It's called Health Equity in England. That can be found on the Health Foundation website. And finally, the disparities white paper. I'll be waiting with interest what's published by the government in the next few weeks or so. So we're hopefully expecting that to be published on the 15th of June. But who knows what's in the news at the time and whether that gets delayed. But I hope that's of interest to you. Happy to answer any questions at any point, Christine.
Marcus?
You talk about inequalities. I think people in Herefordshire at the moment need to be able to see a doctor. There's too few doctors in Herefordshire for the amount of population we've got. And it's very difficult to go and see a doctor and talk to a doctor. And it's also getting very, very difficult to see a dentist. And those are the two things which you should be focusing on. I know the government doesn't only gives money for managers and doesn't give money for local people to do the proper work. And I know the dentists have got a thing against the government, and I know that's why they're all going private. But something needs to be done for the population of Herefordshire so that they get a good health environment. Also, with some of the consultants, they do not tell people exactly what they should be doing and how they should be living. The only way I've been able to do that is to get a cardiologist from Australia. And that has put me on the right path, but nobody in Herefordshire has been able to do that.
And I couldn't agree anymore. I won't pick up any of my primary care colleagues to answer that question. Ginny might want to cover that one later. But in terms of access to healthcare, hopefully that came out. I think that's fundamental. You're absolutely right in terms of GPs having access to care when people need it. And I know as a system, in terms of our primary care colleagues, we're working quite hard to try and make sure that access is available to everyone. I think there is also some narrative as well in terms of how people can help themselves and actually can people do things for themselves, self-manage better, so that actually that frees up capacity for GPs to deal with more complex patients. In terms of dentists, that was raised at our Health and Wellbeing Board a couple of months ago now, so I know that's a priority for the Health and Wellbeing Board. And oral health, I didn't really mention that in children, it is a key priority for the Health and Wellbeing Board as well. So I know that's being looked at. And then your final point about encouraging people to live healthy lifestyles, absolutely agree. There's something called making every contact count, where actually whenever we all come into contact with people, is there an opportunity for us there to help them live their life in a bit more of a healthier way? Can we signpost them to services that might stop smoking or increase their activity levels? So I completely agree with you. I know there's lots of work going on, and hopefully we can improve that over time, but certainly it's an issue for Herefordshire and Stan.
I know that there's an issue at the moment with trans youth and older people too. It seems to be quite a lottery of which school you go to, which teacher you have, which doctor you speak to, whether they respect your pronouns, whether they respect dealing with you in the correct manner. And there has been trans training offered now to the schools, which was turned down. I know that the safeguarding officers in the schools are probably very much for it, but the overall school board seemed to have been not so interested in taking it up, and there's a way to go. I also spoke with the head of something to do with the doctors in Hereford and Worcestershire, and they misgendered a child, and I tried to correct them as nice way as possible, and it was very much shut down. So yeah, there's a lot of work to do on that ground as well, and those are the formative, as you said, those are the formative years, and when you start to get that wrong, that creates damage which will just kind of repeat throughout a person's life. So yeah.
That's a really good point. I think that's probably one for discussion later, isn't it, in terms of how we can support those individuals. Yeah.
Any other questions for Matt? No? Excellent. Okay, so thanks, Matt.